Hello, and welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, and I'm coming to you from the University of Oklahoma Health Sciences Center. But our program, importantly, is a part of the Digital Anatomic Pathology Academy, which is a joint venture between the great platform Path Presenter and the Digital Pathology Association. So our program today comes from the realm of surgical pathology, and in fact is a GI case. And you know that I love GI cases. So the patient kind of happened into this in a little bit of an unusual way. He's an elderly gentleman, well over 70. And I guess, as you know, when you age, you lose a little bit of your balance, and he fell at home. But when he arrived at the hospital, they noted that he was jaundiced. So that, I thought, presents the opportunity to just talk a little bit about jaundice as a presenting symptom. So, typically we think about bilirubin and jaundice associated with elevated bilirubin from the standpoint of kind of where the action is, where the excess bilirubin is being generated, and how it's leaking out into the bloodstream and so forth. And this can happen due to prehepatic issues, such as hemolysis in somebody with sickle cell disease or a hemolytic anemia or something. And certainly elderly patients can develop that. Our patient may have had a large hematoma from his fall, although an acute elevation in near term due to hematoma resorption would be rather uncommon. And usually the bilirubin associated with this type of lesion is the unconjugated bilirubin. Now, we can also get elevated bilirubin due to a variety of hepatic issues. We know that patients with cirrhosis and toxins due to ethanol and hepatitis and various other things can get cholestasis, can get mixtures of types of bilirubin going up within the serum, along with usually other markers as well. So the hepatic list is rather complicated. It includes the toxins and infections we've mentioned, but also drugs and various autoimmune and structural problems like primary biliary cholangitis, primary sclerosing cholangitis, primary biliary cirrhosis, and of course, autoimmune hepatitis. And then we have the kind of post-hepatic, the excretory side of things, where virtually everything is going to be the conjugated bilirubin. And that can happen with, gallstones, partial intermittent obstruction, with biliary tract infections or strictures, obstruction due to pancreatitis, and of course, this great and vast category of biliary and pancreatic neoplasms that can influence the flow of bile. So as it turned out, our patient had conjugated bilirubin elevation. And so we're thinking a little bit more towards the post-hepatic side of things. And that led him to get an MRI study, which we see here in this slide. And admittedly, this is not the highly magnified view, but I think you can perceive here that in the liver, we have areas where we've got apparently slightly prominent biliary ducts. And then we've got a little area of sort of complexity with altered imaging characteristics down here near the hilum with sort of some associated biliary ductal dilatation as well. So that seemed like where the money was. And in our institution, we're able to get to those kind of sites using endoscopic retrograde cholangiography and even biopsy some of that material. So that is what happened. But before we look at what we're going to see here, let's consider the types of tumors that can occur primarily in either the intrahepatic or in the extrahepatic biliary ducts, pre-pancreatic. And that list is relatively long for such a small segment of anatomy. Of course, the most common thing in this location will be cholangiocarcinomas. And in fact, that was the presumption of the radiologist who interpreted the MRI scan, that this patient likely had a cholangiocarcinoma. But we can also get neuroendocrine tumors in this location that can cause obstruction. They're certainly less common than in other areas, but they do occur. Then we have this group of intraductal papillary neoplasms that is kind of a mixture of tissue types that can include sort of a mucinous intestinal type, sort of what you'd see like in the pancreas, oncocytic tumors, pancreatico-biliary type pattern epithelium, and even gastric pattern epithelium in these papillary neoplasms. And we have seen and done videos previously on the mucinous cystic neoplasms that have ovarian-like stroma and can occur in this location, as well as the gallbladder and so forth. There's also an intraductal tubulopapillary neoplasm, which has relatively little papillary growth. And finally, theoretically possible also to get solid pseudopapillary tumor in this location. So here's a representative section of the tissue that was retrieved by ERCP. And as you can see, we get really quite a lot of tissue. We have some areas that look like there may be necrosis associated with this. But we also have this very rich cellular, complex glandular tissue here with a considerable degree of papillarity and complexity to the tissue, some associated stroma, and as you can see here, relatively orderly pattern of growth, but certainly very florid. When we come into higher magnification, it's very interesting to see that these cells all have very nice, round, uniform nuclei, generally located at the base of the cell. There's minimal hyperchromasia to the nuclei, no variability in the nuclear membrane, and the nucleoli are almost inconspicuous in this tissue. So fairly low-grade appearance to this tissue, and it looks to be very similar to the sort of type of epithelium we would think of as pancreatico-biliary. I mean, you could imagine this being a biopsy of a bile duct and seeing these as sort of peribiliary type glands. And there is, of course, some inflammation and other features going on here, but no frankly invasive or desmoplastic reaction in this tumor, but a large amount of intrahepatic growth, or the intraluminal growth of the sort that we have described. So based on that histologic appearance and looking here at our list of intrahepatic or biliary-based neoplasms, we're probably not looking at cholangiocarcinoma. So, hey, we still need pathology. We can't rely totally on the radiologist to call it. But in fact, we are probably dealing with an intraductal papillary neoplasm. And most likely here, we're looking at the pancreatico-biliary type of lesion. So let's talk a little bit about these lesions. Of course, a similar type of neoplasm can occur in the pancreas, but here we're talking about the lesions outside of the pancreas. Now, in many audiences or many populations, this is very rare, but in some locations, the Far East in particular, Korea, Japan, Taiwan, maybe portions of Southeast Asia as well, and China, this lesion can be more common. And that may be due to sort of an endemic infestation with Clonorchis sinensis or other liver flukes, or other dietary or genetic factors. The sad portion, of course, is that there is a very high rate of associated invasive carcinoma that follows this more typical dysplasia carcinoma sequence that we see in so many organs. So detecting this lesion and the fact that we found only sort of low-grade in situ kind of disease doesn't preclude that there isn't invasive carcinoma elsewhere in this patient. And of course, this is a very difficult lesion to treat, depending, of course, upon the area and extent of spread. In terms of differentiating those different histotypes that we mentioned earlier, and there may be some value in that due to the fact that certainly the pattern of invasion and the particular subtype may be more prone to invasive disease. You can use the MUC immunohistochemistries to differentiate the gastric, which will be positive with 5AC, from the intestinal and pancreaticobiliary types, which would be MUC2 or MUC1, respectively. We did not feel that was necessary in our case. Certainly the histology was quite characteristic of the pancreaticobiliary type, and the treatment being proposed for him was going to be fairly limited given his age and the extent of disease that he had. So providing some stent and drainage so that he wasn't uncomfortable due to the jaundice, and whatever palliation that would be appropriate given his age was opted on for therapy. So our final diagnosis in this case is intraductal papillary neoplasm, pancreaticobiliary type. And I hope that you found that useful. Unfortunately, I can't provide at this time a link to the digital slide on this case, but if you're interested, I'm happy to talk to you more about it at any point. Please feel free to reach out to me. And as always, thank you so much for joining us. We hope you'll subscribe, and that will allow you to get notice about future releases from our channel, which we try to do fairly regularly. And we always welcome your comments, feedback, and impressions about what we're producing on our channel. So until next time, thanks so much for joining me. I look forward to seeing you again.